and very ably supported by departments of radiology, otolaryngology, and pathology. So may I request Shriyoshi to present the case, please.
Good afternoon, everybody. Today I am presenting this case of a 13-year-old boy who presented to the ENT OPD with chief complaints of left-sided facial swelling since 1.5 years and nasal obstruction and bleeding from the nose since 1 year. Left eye protrusion since 8 months. The patient presented to the Department of ENT on the June of 2024. He was apparently asymptomatic 10 months back when he developed progressive left-sided facial swelling. During the same time, he also developed left-sided nasal obstruction, which was insidious in onset and progressive to bilateral nasal obstruction, and it was also associated with snoring. He also gave history of nasal bleeding since 1 year, which was spontaneous and intermittent, amounting to 100 ml per bleed, which is managed conservatively. The child then started developing painless protrusion of the left eye since 8 months, associated with the diminution of vision in the left eye, which progressed to complete loss of vision within a month. There was no history of headache, seizures, loss of consciousness, no symptoms suggestive of neurological deficit or cranial paralysis. There was no history of decreased hearing, sensation of fullness in the ear, or ear discharge present. Past history, there was no history of trauma, nasal surgery, or prior radiotherapy, no significant medical or surgical illness, or any documented allergies in the past. There was no similar complaints in the family. Growth and development were appropriate for age, and no bowel and bladder complaints were present, though the patient reported disturbed sleep and reduced appetite. Coming to the clinical examination, the patient was alert, conscious, oriented. He was a thin boy with stable vitals. There was no pathologic diagnosis of clubbing, generalized lymphadenopathy, or edema present. On examination, there was a left-sided swelling, which was 5 to 4 centimeters, involving the maxillary region and stretching the overlying skin, while sensation over the face was normal. Left eye process was seen with normal extraocular muscle movements. Visual acuity on the right side was found to be 6/24, while perception of light was found to be negative on the left side. On nasal cavity examination, a fleshy mass was seen filling up the left vestibule with mucopurulent discharge over the mass, septum being pushed to the right, and the right nasal cavity was filled with mucoid discharge as well. On oral cavity examination, mouth opening was normal, with a soft palate noted with a fleshy mass in the oropharyngeal region, causing 90% luminal compromise. There was no palpable neck nodes, and cranial nerve examination was the investigations with which the radiological part will be now presented by Dr. Shishma.
Good afternoon, everyone. I will be presenting the imaging part of the case. So, a 13-year-old male with clinical profile, as discussed by Dr. Shriyoshi. We have the coronal sections. First one is the T1 weighted image, second one is the T2 weighted image, and the third one is the post-contrast image. Getting oriented to the scan, this is the at the level of the orbits. We can see a large infiltrative soft tissue lesion involving predominantly centered around the nasal cavity, involving bilateral maxillary sinus as well as extending into bilateral orbital cavities. Superior inferiorly, we can see the lesion is extending into the anterior cranial fossa, and the lateral extension of the mass, as can be seen, it is going through the pterygomaxillary fissure and emerging into the inferior temporal fossa on the left side. So a large enhancing, and on the post-contrast images, we can see the lesion is we can see the this is the pterygomaxillary fossa, and it is exiting and involving the infratemporal fossa. Bilateral maxillary sinuses are involved. There's involvement of the bilateral intraorbital cavities, and we can see a large enhancing region within the intraorbital component more on the left side, correlating with their clinical features of the left eye proptosis. There is this anterior cranial fossa extension abutting the basofrontal lobes, and we can see also this enhancing dura bilaterally. So there is an intracranial extension, intraorbital extension of the lesion, as well as the infratemporal fossa extension of the lesion. So this is the sagittal image, mid-sagittal image showing us the craniocaudal extent of the lesion. The cranial, again, it is going into the anterior cranial fossa, posteriorly involving the sphenoid sciences, anteriorly completely filling the nasal cavity, and posterior inferiorly involving the nasopharynx hole and going up to the oropharynx and involving the hard palate as well. Going on to the axial image in the intracranial aspect, we can see the lesion is superiorly through the cribriform plate and all the way going from the anterior cranial fossa up to the middle cranial fossa. It is completely encasing the bilateral and bilateral intracranial ICAs and displaying the left ICA. And there is also this mass lesion presenting in the medial aspect of the medial temporal lobe, causing it scalloping. So there is definitely intracranial extension, but extradural. It is not going into the brain. This temporal lobe, it is causing scalloping of the lesion. So the medial-lateral extension on this axial image can be seen. Bilateral maxillary sciences are involved, and posteriorly going up to the prevertebral space. So by now, looking at the clinical profile of the patient and this intensely enhancing infiltrative lesion with a characteristic pattern of spread along the left intratemporal left maxillary fissure and going into the intratemporal fossa. We keep the possibility of the juvenile nasopharyngeal angiofibroma. Keeping it in view this characteristic spread of, there is no differential in this case. The further case will be taken over by the Dr. Ekansh. Go ahead.
Good afternoon, respected faculty and residents. I'll be presenting the case in ENT team. First side is slightly contradictory to what we feel. It starts with a biopsy. So usually in JNA, it's not advised to do a biopsy, rather it's contraindicated. But in this case, due to some atypical features in imaging, like Sir told, there was some dural enhancement. There are a lot of large cystic spaces, which is not characteristic of JNA, although the spread is somewhat what we expect for a JNA. So keeping a reasonable doubt, we proceeded with a biopsy, which was under general anesthesia, because these tumors are very hard to stop when they're bleeding because of the lack of muscular layer in the vessels. After getting a positive report of a JNA, which was already suspected, we proceeded with resection of the tumor. To reduce intraoperative bleeding, we usually use multiple strategies, usually involving either pre-op medications or embolization. In this patient, we did not do either, again because the patient was prepubertal and the flutamide does not have a great efficacy in prepubertal males, and it also delays their development. So flutamide was not given, and due to logistic issues, patient could not undergo embolization. Intraoperatively, we did a maxillary swing, basically opened the maxilla like a book, saw the tumor upfront as much as we can, exposed the tumor all around, dissected it from all ends and removed as much as we could. There was a large expansile tumor as we saw in the imaging, and surgery to control over them to control the bleeding. Even after that, the bleed was around 2 liters, which is considered good in such an extensive case. We have seen bleeds for up to 4.5, 5 liters in kids as young as maybe 8-9 years old, 2-3 times the volume. I think this part will be taken Dr. Ashima from pathology. Thank you.
What's the reason why biopsies are not done in JNA?
Because the vessels in JNA does not have a tunica media, which is the muscular layer. There is no spasm of the vessels. If we manipulate the vessels anywhere from the outside, they are not able to go into spasm. We are not able to cauterize it. We are not able to control it with any of the hemostatic agents we have. So during dissection, we have to go from around the tumor, take it out like a ball. Else, if we start bleeding, we won't be able to. Thank you.
So coming to the histopathology part, we saw that this is in a low powered image, and we saw that there is multiple vessels can be seen which are dilated to slit like blood vessels, and it is surrounded by very blank looking stroma. Next, going to the high powered, this stroma is predominantly composed of fibroblasts, which showed very mild nuclear pleomorphism, and we are seeing ill-defined cell border, abundant cytoplasm, and this vesicular
chromatin and prominent nucleoli we can see, and there are some mast cells which can see, which are very small cells which are having hyperchromatic nucleus, and many vessels showed fibrin thrombi which happened due to pre-operative embolization. So this is a very typical case of juvenile nasopharyngeal angiofibroma. To further substantiate our finding, we did androgen receptor, which came out to be a nuclear positive, and which shows that it is a hormone-driven tumor, and beta-catenin, which came out to be also a nuclear positivity. So this also indicates that there is a somatic mutation of CTNBB1 taking place. So this feature shows that it is juvenile nasopharyngeal angiofibroma. It is a clear-cut case, and we don't have any other differentials. Thank you.
They said they didn't do any pre-op embolization. You said that the pathological findings suggests
A fibrin thrombi itself.
that has nothing to do with.
No, that is nothing to do with that. Is just a finding we found in many vessels.
Foreign material to the process where we say embolization. Can be there.
So the patient had a symptom has had symptom relief post surgery, and he remained largely symptom free till 4 months post surgery, when he presented again with complaints of facial swelling, protrusion of the left eye, and left sided nasal blockade, discharge in the left nasal cavity with intermittent nasal bleeding. The patient was then referred to the head and neck multidisciplinary clinic. Where on clinical examination, the patient had an ECOG PS of 1 with a 6 into 5 centimeter diffused facial swelling on the left side with left eye proptosis and conjunctival edema and redness. There was restrained eye movements as well as pupillary reaction was absent along with the perception of light. There was flattening of the nasolabial fold and dilatation of the nasal root with fullness of the left cheek, as well as a bulge was seen on the soft palate. A CMRI face was done on the 2nd of February of 2025, which showed a large mass in the pterygopalatine fossa involving the infratemporal fossa, the sphenopalatine foramen, the masticator space, as well as the sphenoid maxillary and ethmoid sinus, causing their bony destruction. There was the disease was also extending into the orbital apex and encasing the optic nerve, while involving the cavernous sinus and encasing the cavernous internal carotid artery. Posteriorly, it was extending into the paravertebral space and causing oropharyngeal airway indentation, resulting in the narrowing of the airway. The patient was discussed in the head and neck clinic, and in view of the locally advanced nature of the disease, the tumor was surgically inoperable and therefore planned for radical radiotherapy. The pre-radiotherapy investigations included complete blood investigations and purine audiometry and pituitary hormonal assay, which were found to be normal. On ophthalmological evaluation, the visual acuity was found to be 6/24 on the right side, with a perception of light being negative on the left side. During radiotherapy treatment planning, the patient was placed in a supine position with the neck being extended using a headrest with hands by the side. Separator was kept within the oral cavity, and a thermoplastic cast was used for immobilization. Injection Omnipaque at 1 milligram per kg was injected, and a planning CCT was then acquired with 2.5 millimeter slice thickness in the treatment position from vertex to the hyoid. Images were then exported from the CT simulator and imported onto the treatment planning system. As we see the disease status at the time of planning CT, it was a very large disease and it was involving and causing erosion of the surrounding areas. The planning CT was fused with the pre-RT MRI for delineation of the gross tumor volume. And the gross tumor volume was further delineated using information from the pre-surgery MRI as well as the pre-RT MRI. The gross tumor volume was then given a margin of 3 millimeter to form the planning target volume to account for the daily motion as well as other planning irregularities. Here we see the organ at risk or the critical organs which are surrounding the disease, and which includes the eyeballs, the bilateral temporal lobes, the brainstem, the optic nerves, the parotids, oral cavity, as well as the maxilla and spinal cord. So this is a slide showing our radiotherapy plan. Patients plan for radical radiotherapy to a dose of 50.4 gray in 28 fraction using partial arc VMAT technique with 6 MV photons. We can see that the high dose region conform very well to the PTV while respecting the dose constraints of the organs at risk. The patient completed radical RT to a dose of 50.4 gray in 28 fraction with effect from 17 March 25 to the 1st of May 25. He tolerated the treatment well. There were no treatment gaps or major toxicities apart from occasional nosebleeds, and they were managed conservatively. At the first follow-up, the patient had symptomatic relief, and at the 3-month follow-up post-radiation, the patient had 40% symptomatic relief with reduction in the facial swelling and reduction in conjunctival edema. Grade 1 dermatitis was present, and perception of light was present in the left eye with no further nasal bleeds reported post-RT. The response of the patient to the radiotherapy would be now discussed with Dr. Shajat.
So I will be discussing the pre-radiotherapy CMRI and the post-radiotherapy MRI. Look at the response. So these are the pre-radiotherapy scans showing the recurrence of the lesion, again involving the bilateral maxillary sciences reaching up to the prevertebral space. The dramatic thing to see is that there is the left eye is severely proptosed, and there is a largely enhancing lesion in the left retroorbital space, and there is also involvement of the cavernous signs on the left side as well. So these are the coronal images showing the craniocaudal extent, and again showing this large intraorbital which has dramatically increased compared to the previous scan. Although the center of the lesion does show these cystic areas which have increased compared to the pre-surgical scan. So this is the post-radiotherapy scan, 3 months post-radiotherapy. We can see the center of the mass that has been completely replaced, completely cavitated, and it is filled by the air-filled cavity. What we can see is there is the peripheral ring of tissue that is irregular, that is thick, and that is enhancing. That shows that it is a residual tumor which should be followed up over time to document the response, complete response. So this is the actual image. These are the sagittal and the coronal images showing the complete cavitation. So this is the comparative image showing side by side the pre-radiotherapy and the post-radiotherapy. This whole enhancing lesion in the center has completely cavitated and leaving this ring of enhancing tissue in the periphery. Greater than 90% of the lesion has completely cavitated, leaving this ring of tissue. This should be followed up further if there is a response further on. This enhancing thickening should decrease with time. It should remain very thin, and it should not be this much nodular to document the complete response to the radiotherapy.
So coming to the review of literature,
You have to do
yes.
it in a much time.
So juvenile nasopharyngeal angiofibroma is a rare tumor arising from the nasopharynx, accounting for less than 1% of all head and neck cancers affecting males from the ages of 14 to 25. And it originates from the vascular endothelial cells of hypoplasm and has a vasoproliferative nature. And the etiology is yet unknown, though an antigen-dependent growth has been hypothesized. Surgical treatment aims to remove the tumor, but it often presents as tumors which involve the base of the skull, making complete resection difficult. Therefore, though histologically benign, JNA is Locally invasive and associated with a high rate of persistence and recurrence, primarily due to the incomplete surgical resection, therefore making RT an effective primary and adjuvant treatment option in JNA. So these are some of the trials from 1984 to 2022 where radiotherapy has been used in the treatment of RT, where we see they have either been used in definitive treatment or after local recurrence. So we see that the local control is close to 91% in many cases and even reaching 100%, while the response rate though is low and is occurring only at 18 months or even later. The toxicity is less in most of the studies, and the next study is from our institution in our department, where it was conducted between 1990 to 2012 with 31 patients and with patients receiving RT for refractory, residual, and unresectable locally advanced disease with a median radiation dose of 32.5 day with a median follow-up of 36 months. At the 13 patients were found a radiological response at 3 years, and a longer follow-up, the progression-free survival was not reached, and the progression-free survival at 3, 5, and 10 years were 91.7, 70.7, and 71% respectively. This is a case report from the Department of ENT in AIIMS, which is of that of an 18-year-old male patient presenting with locally advanced JNA, who was treated with 30 grade 15 fractions EBRT, and on follow-up, the disappearance of tumor was noted gradually over time, and complete response was noted at 3 years post-treatment. Therefore, reaffirming that from the earlier studies that GNA mass regresses gradually after completion of RT. Dr. Anjali will now be talking regarding the further discussion.
So in this case, why this case was unique is because usually the response rate takes from 6 months to 3 years or further up to 5 years. Even the patients which we used to treat, the response is gradual. We used to see a stable disease, then over time it regresses. But in this case, immediately in the first month itself, following the 3 months imaging, we saw a rapid response where the entire tumor has disappeared, melted away with radiotherapy, and therein, obviously, we have to follow up the patient, and we are expecting over time this will be controlled. That is the unique case which we found, because in majority of the literature, we were not able to see this much of complete response or drastic response immediately after radiation. Every literature studies, it takes up to 18 months to 3 years to have this sort of response. So the session is open for further questions. When we are treating with a definitive curative intent, we use the term radical or definitive radiotherapy. When it is given immediately post-operatively, the term adjuvant treatment is used. So in this case, usually benign tumors, we keep the patient under close follow-up. When the tumor progresses, then we try to intervene. Because it is a benign tumor, it is a kit. So radicalist term is used when we are treating the patient with a curative intent. Yes, but locally aggressive this nature.
I have a question to complete then. Really, after biomarkers to predict which cases are going to respond to radiotherapy. Actually, that is related to the question I was planning to ask. Do you have an explanation for why he has done so well?
Yes, the answer we don't have much. Mainly all the test reports, everything, it's fewer number.
Local control is
Excellent.
80 to 90% of response. In this patient, there is a very rapid response.
Look at some cases over time and see maybe the response to that.
Yes, usually we see a gradual. The other patients, we used to see a gradual response, the treated patients. As of now, there is no stand. It is not a standard of care.
More robust. Any cause effect is identified for the
Yes, sir, we need to, like, as of now, we don't have any literature supporting why this rapid response or for this patient. We have the histopathology, it is JNA, it is nothing else. So we need to see further molecular markers which make it this much responsive. As per the literature, we don't have much evidence which tumors are behaving better, because otherwise it is a very locally aggressive nature, because within 4 months, 3 months of surgery it came back, similar size with intracranial and proptosis, the patient even after immediately after post completion of radiotherapy, the patient was able to close his eyelids. Otherwise, he was not able to close the eyelids, and the entire oropharynx was filled with the mask. Patient was not able to take breathing through the nostrils. And for during treatment also, we kept a tube which by which the patient is able to breathe. JNA, yes, we need to.
Sir, imaging wise also it's not a typical JNA. There are cystic areas which are unusually seen. These are homogeneously enhancing masses. So imaging wise also it is somewhat different from the routine spectrum of JNA findings. Maybe that could be a reason for some we should look at. Yes.
separate those patients in separate steps.
Yes. We can do a retro. Already 2012, we have the studies from 2012. Whoever has a very good response, we can have a pathology retrospective and repeating. And if we are able to come out with some molecular marker which predicts the response, it will be very good. Thank you all.